Good morning. I'm Peter Piot, and I'm chairing this first session of the conference, it is on the global burden of disease. And there is nothing like the global burden of disease. It's unprecedented in terms of not only a massive undertaking, bring everything together, but also it is now, I think, was also very much needed. Having contributed in my previous life on trying to estimate the burden of AIDS and on specific issues, and then many communities, disease-specific communities have done it. It was really high time that it all came together. And thank you, Chris, and your team, and of hundreds of collaborators to have done this. This is, of course, not without challenges, and these challenges will continue, and we'll hear some of that. But the massive coverage in the media, not only in specialized media, but also in general media outlets, I think is an illustration of how relevant the whole exercise has been. And there's been some healthy debate, and we'll come back to that at the end, I assume. What's important now also is that we go from the global to the country, and even in some countries to sub-national levels. And we'll hear a few reports on that from the Americas and from South Africa. And that's key in terms of the burden of disease exercise and impact on policy and decision making. So I won't go much further with my introduction. I'll have some reflections at the end. This session should also set the tone in terms of how we work. Each presenter has 15 minutes, 15 slides, and the three people will give the presentations, in one go. Oh, we're four. Ari's there. Oh, sorry, I was told.
We swapped Martin in.
Oh, Martin. Okay, thanks. So we'll have the four presentations in one go, and then we'll have the discussion. So Chris, you'll start. Thank you.
Okay. We thought, given that there were so many abstracts in this conference that related either to subnational, national, or the global burden of disease work, or critiques thereof, or proposed improvements of methods, it would be appropriate to give one presentation on the overall study provide context for those who aren't as familiar with it. So let me give a quick overview of the Global Burden of Disease 2010 study. We like to think of it as a systematic emphasis on scientific effort to quantify health loss from a broad array of diseases by country and over time. Diseases are quantified at the level of sequela of diseases. So we have 291 diseases, but 1,160 sequela. And we also look at the burden attributable to risk factors, some 67 risks or combinations of risks. The study was funded by the Bill and Melinda Gates Foundation, and summary papers were published in The Lancet in December, and there are many other publications that are either have come out or in the process of coming out. Now, this is a large collaborative undertaking with scientists from really around the world, 50 countries involved, covering diseases, injuries, risk factors, and some of the central efforts at computation as well. And this map shows not where the study gives results, but where the investigators come from. For those of you less familiar with the burden of disease, just a reminder of terminology you will hear throughout the conference. The notion around burden is a quite egalitarian one. It's the idea that we should compare population health in each setting to a reference norm, that everybody lives in full health to a reference life expectancy of 86 years at birth. That has two dimensions: premature mortality, and we measure that as years of life lost by taking a death at each age and counting up the number of years as represented by life expectancy in the reference population at that age. And years lived with disability, which is simply the prevalence of different sequela times a disability weight for those sequela. And DALYs are the simple arithmetic sum of those two quantities, YLLs and YLDs. Now, there's lots of components that go into burden of disease assessment, and I'm not going to work through this slide or even the more detailed slide that I'll show in a moment, but just to point out that abstracts throughout the conference will touch on different parts: the demographic part at the top left, the cause of death analysis in the green boxes, the prevalence of YLD and the disability weights component in the purple and orange boxes, and the risk factor part in the blue boxes. Each component can be sort of laid out in a sort of almost, not a mechanical, but a very clearly defined series of processes, both to take different data sources, adjust for bias, and synthesize the world's data that's available for each of the quantities of interest, and that's what this rather complex schema shows. Now, that's it for a brief overview of the goals and the methods for the study. Of course, there's a lot written about them. I'm sure it's going to come up in some of the detailed presentations during the conference. There's a workshop during the conference for those who are interested in a deeper dive on methods. But what I'd like to do is show you some of the key results, not using slides, but by using some visual tools that are online and available to all. First, to note that the underlying primary data for mortality and for cause of death is available online. Here's an example of the US for tuberculosis with an online tool. You can mouse over each of the data points and get all the metadata related to that source. You can also see how one of the key components around the burden of disease, which is to make cause of death data more comparable by dealing with garbage coding, how that affects the results by flipping between the pre-adjusted and the adjusted tabs on this tool. But I will not spend more time in going through the raw data sources there, but simply to point out that's a resource available for everybody. The analogous tools for the descriptive epidemiology of sequela are not yet available, and I'll talk more about that at the end of this presentation. Okay, to some results. If we go back to 1990 and look at deaths in the world, you can see for, by age group, and there's 4 age groups for children shown here, and then 5-year age groups out to 80 plus. And causes are divided into 21 broad cause groups. Pneumonia and diarrhea in yellow, neonatal causes in this purple color, cancers light blue, cardiovascular disease the darker blue, chronic respiratory shown there. From 1990 to 2010, there is a substantial change in the cause structure of mortality. Deaths have shifted to older ages, and there's been a reduction from over 12 million child deaths to just under 7 million child deaths. But one of the fundamental principles around the burden of disease is that as a metric, deaths is not a great metric because it doesn't really capture the loss associated with each death. And that's why if I shift to a years of life lost view, you'll see that, and I'm going to make the scale come back here, you see that when you look at years of life lost, the 7 million child deaths in the world still represent a huge volume of premature mortality. And also the deaths in young adults, HIV and tuberculosis, road traffic accidents, homicide, suicide, other injuries, represent a very substantial amount of premature mortality as well. So in a sense, you have 3 blocks there: the premature deaths in children, diarrhea, pneumonia, neonatal causes, a few others, the young adult causes, and then what you probably tend to think of as more commonly the cancers, cardiovascular disease, chronic respiratory disease in older adults. The other component of the disability, of the burden of disease, is disability. And here, one of the key findings globally is that the volume of years lived with disability is going up substantially due to the fact of aging of the world's population into age groups where that is more common, disability is more common, and that the prevalence rates for disability have not changed much in the last 20 years, declines of only 6 or 7% globally, in contrast to very substantial declines in age-specific death rates. That means that the volume of burden is shifting progressively towards disability, and the key causes of disability help us understand how this is occurring. The big green bar here is the mental disorders and behavioral disorders. The light purple is musculoskeletal disorders, low back pain, neck pain, rheumatoid arthritis, osteoarthritis. And then you have a category that includes vision loss, hearing loss, congenital anomalies, and anemias that's also an important contributor. And some of the infectious causes, malnutrition, HIV, TB, and the cardiovascular causes, while important, are relatively small causes of disability in contrast to very large causes of premature death. When we put that all together, what we get is DALYs, and then you get the complex picture that we know as the global burden, namely big causes of premature death in children, both disability and premature death in young adults, and then a pattern progressively dominated by premature death in the older adult age groups as well. Now, a key part, and one that's probably generated more debate than the disease and injury component of the burden of disease work, is around risk factors. And so I'll show you here the risk factor view at the global level. So here is DALYs, the percent of DALYs, which I'll change to on this view, attributable to each risk factor. And if I go back to 1990, what you find is that childhood underweight, household air pollution, suboptimal breastfeeding, and some of the micronutrient deficiencies were important causes, and they had a contribution to the childhood causes of premature death, as shown in the red components of these bars. If you fast forward to 2010, the global frame of risks has changed rather profoundly, so that those causes have all declined substantially, reflecting the drop in child deaths from 12 million to under 7 million, and also a decline in exposure to some of those risk factors. And in contrast, the more dominant risk factors at the global level now are diet, high blood pressure, smoking, household air pollution, still a cause of premature death in children, alcohol use, high body mass index, and high fasting plasma glucose. So a true global risk shift. And having said this, at these shifts at the global level, let me just point out that country by country, the pattern of burden is still very different. So if I stick a map on here and show the fraction of the burden of disease on the bottom that is related to the communicable maternal and neonatal causes, even though we've seen big global shifts, if you go to a place like Niger, you're going to find out that the burden of disease is still dominated by the communicable maternal and neonatal causes, shown in red in the top square pie chart called a tree map, and shown in the map at the bottom. So outside of sub-Saharan Africa, profound shifts in the burden of disease towards non-communicable diseases, towards disability. Within sub-Saharan Africa, substantial progress in reducing death rates, but a burden of disease profile dominated by childhood causes, malaria, HIV, and tuberculosis. Now, let me close with a few comments about what's happened since the publication of the burden of disease. So the papers were published in December, and as you would guess, there's been a vigorous set of presentations in many disease, injury, and risk factor specific scientific meetings, but also in a number of broader discussions around the overall findings, implications for research at NIH, and engagement in a number of policy groups in what does the descriptive epidemiology tell us about new trends and new challenges for the future with organizations such as the World Bank and the European Commission, amongst others. But interestingly, in a very short period of time, there's also been a robust engagement of using the country-specific results in the burden to trigger national dialogues about health priorities. The first was with the UK government, leading to a jointly authored paper with some of the new leadership of Public Health England and the NHS Commissioning Board, published in The Lancet in March, and a response from the Secretary of State for Health, Jeremy Hunt, with a call to action. A policy discussion with the Minister and the National Institute of Public Health in Norway, a high-level discussion in China, and a publication, I think, just a week ago of an analysis with leadership from China CDC and the Peking Union Medical College about the implications for China. Similar discussions have taken place in Indonesia, in Australia, in a regional discussion, and there are many more of these still scheduled to come, including, we're excited, that the burden of disease results seem relevant here in the US as well. Now, for those who were and are in the future interested in a very deep dive into the methods, we've already had our first detailed 10-day in-depth training event around GBD methods and tools with 88 participants from 35 countries held in May, which I think, given a new study and the need to generate completely new curricula to try to teach these new methods and approaches, that was done very quickly and was a testament to the efforts of our education and training program at IHME and also of many people that worked on the GBD in helping that happen. So we expect more of those in the future as interest, as we recognize broad interest in the details. Where's this work going? Well, not too long ago in The Lancet, we announced that along with Trevor Mundell from the Gates Foundation and Peter Piot and Julio Frank, the plan for a continuous version of the global burden of disease as a global public good. The idea is the first of these updates will be this year, which will be the GBD 2012, and hopefully released in December, that will, in the first go, capture all the things that people have come up with and said, oh, you didn't use this data source, or you could have done a better job in the analysis on a particular outcome. So all that critical input and feedback will feed in, we hope, to the first revision. But this process will also change, we believe, the nature of how the GBD is undertaken, because we hope to both broaden the collaboration around disease, injury, and risk, but also broaden what is already happening organically, which is this engagement with countries, with collaborators organized by country who are interested in the broad epidemiological patterns in their country and not just in a particular disease, injury, or risk. We also plan to expand the scope of the burden of disease to add back what we had nearly 15 years ago, which is forecasts. We also plan to add tracking of health expenditure by the same disease and injury categories in the GBD. And although not as part of the current plans, but in the long-term vision, have a stronger linkage to the evidence base that's out there on what interventions work in different settings to address the burden that remains from different causes. And last, not work that will be done centrally, but we see being driven by country collaborators and researchers around the world, and we'll hear some examples of that in a moment and during the course of the conference. Hopefully a new generation of subnational studies that will be consistent with the at least definitions and methods used globally, but provide new insights and improve both the national assessments, but also the subnational assessments of burden. Thank you very much.
Thank you, Chris. It's good to hear directly from the master himself, or the architect, as they would probably say in the world of IT. We'll come back to maybe some of the issues that Chris put on the table in terms of the future, because I think that's really important. Now we'll have a regional perspective from the Americas by Fatima Marinho, who's the Regional Health Observatory Advisor of Pan American Health Organization. Fatima.
Thank you. Yes. Well, So I will talk about the regional perspective, but using our information in for the Americas. We'll talk a little bit about the change in the region, so demographics, economics, epidemiological transition, burden of disease, the challenges, avoidable mortality, inequalities, children, premature death, and try to focus more in some population groups. So the region of the Americas we have a diversity, so we are not just how everyone says that's the most unequal region in the world, but we have a diversity in the region. So, and we have a huge inequalities. And our change in the region, we can see that the region has improved some indicators. Our population has, since the 70s, we have twice the population. The life expectancy increased about 13 years in this period since the 70s. The fertility rate decreased. The economic situation in the region is better now than in the 70s. Even the death rate has decreased and the age index has increased. And the infant mortality decreased, as Chris showed to us, in the world, but it's also in the region. So what does it mean? That means that region is better. That means that the average is still higher than inequality. So we can see the population in Cuba and in Nicaragua, and we can see the difference between two countries in the region, two Latin countries. And we can see that the average is still is a problem for us, that you have to focus more on the population and some groups in the population. For the epidemiological transition, we have in the region at least 3 models of this transition. So one model could be Uruguay, the US, Canada, and Chile. When we have a high proportion of NCD since the 50s, and we have a low proportion of infectious disease, and not so high proportion of violence or external cause of death. The other model, that's intermediate model, or second model, could be Brazil, Mexico, Colombia, Costa Rica, and Venezuela, and maybe other countries, but we don't have information for other countries. So there is just an example here for the high proportion of infectious disease in Mexico in the 50s. They responded for 61% of overall death. And NCD, or non-communicable disease, 22% during the 50s. So this proportion of the NCD increased, and the infectious disease decreased, and the violence increased also. So it's one kind of a transition that is still a transition in this process. It's different from Uruguay or from the US or Canada. And the third model, we see Ecuador and Guatemala. This example is from Guatemala. And we can see that Guatemala, we still have high burden of infectious disease. In 26, they were 30% of NCDs in Guatemala, and 30% of infectious disease, and 46% of non-communicable disease. And the injuries in Guatemala increased from 3% to 18% in the same period. So it's another kind of a transition also here. And if we look at more recent data, you can see in the bottom, Guatemala with 48% of non-communicable disease, and in the top, Canada with 80%. And the average of the region is 76% of non-communicable disease and 13% of infectious disease. If we look at the decline in children mortality or infant mortality, It's decreased 80% since 2000. And the region is on track for the MDG4, but the problem is just less than half of the countries is on track. So we have inequalities here in the region, the difference among countries, and we have different progress or different performance of the health systems. So you can see since the 1985 analysis of the trends, and we can see in red Chile and Guatemala. I got two Latin countries to compare. I don't want to compare Guatemala with Canada, but I think it's possible to compare with Chile because we can see that even Guatemala taking intestinal infection starts with a high rate, the progress was lower than the progress in Chile. So why this difference? Maybe Chile focused more on the vulnerable populations. One part of this analysis is the information, but I will not comment on this. I will wait for the questions. And respiratory disease, that is still a problem in the region. This is analysis for children under 15. And we can see that respiratory disease a high rate even for Guatemala or even from my country, Brazil, or Colombia, or Mexico. It is still a problem. It's still causing a lot of death in the region. And if we look closer to some groups in the population, now we can see indigenous people in Brazil compared to non-indigenous people. It's children under 5 years. I got intestinal infections, respiratory disease, and malnutrition. That's the leading cause of death among indigenous in my country. And I brought the data from Brazil because some governments don't want to make visible the invisible. And I got counsel, someone told me that, take care because some countries could be offended because you are showing their reality. And no one likes to look at this reality so close. So that's why I brought the data from my country that I know we focus on this problem, but it is still a shame because the difference is so huge. So we will not drop this problem. So we will not make more equal the world and the countries and populations without focusing in some groups. So if I have an average in Brazil, like diarrhea or intestinal infection, 2.5 as a rate, and I have more than 100 for indigenous, it's still a problem. The average, again, is hiding the reality. The average does mean that the whole population is having the same benefits. So what to do? We have increasing the homicides in the region. If you see in the green line, it's Mexico. No, sorry, it's Brazil, and Mexico is the red one that has recently increased the homicide and is getting closer to Brazil, one of the highest rate in the region. And we can see in Colombia, the homicides decreased, and it is increasing in Central America countries. It's also increasing in Mexico. So another problem for our situation in the region that's more difficult to work. And another question is the communicable disease. I brought in the graphic the cardiovascular disease decreasing for some countries, increasing in Guatemala, and stable in Mexico. And we can see here in the model, and circulatory disease, that is ischemic cerebrovascular hypertensive disease, the progress, so some countries decreasing, other countries increasing, and diabetes that is increasing in all the countries in the region. Diabetes will be a huge problem in many countries, and right now it's a problem in Mexico, as you can see. Well, what are our challenges? To reach health equity, we know that inequality exists in all countries, from the poorest ones to the richest one. We have just to make visible the invisible, so we see the inequalities. Focusing population lives in disadvantageous conditions, gender equality, ethnic equity, and intercultural approach is one strategy to work to reduce the inequalities. A better distribution of richness should be part of these social policies because it's impossible without share the riches in the countries. And guarantee the access of health services is critical for the reduction of social inequality. So another part of our efforts in improving information is improving information to improve the care. Not just improving information for our publications, but to make useful the information to guide the policymakers and make the information available to everyone, to civil society, to make more conscious the civil society and take intersectoral actions like homicide will not have a good result if you don't work together with other policymakers, and social participation are strategic. Without social participation or civil society participation, social movements participation, we don't get equity, will not improve the care, because it's important the way that the population look at their own problem. We from the health service, we from the government, or we from the academy or universities, we look at the problem that's not exactly our problem, it's our subject. But for the population, their problem, they live it, they suffer the problem. That's why we need much more participation from this population to make a kind of fusion, our visions. We could be working together and improving the policies and improve our cares. It's a policy in my country, in Brazil, that's by the law, social participation is mandatory. Everyone, we have a council, a federal council, states, municipalities, and health facilities councils. It's mandatory. Half of them be from the population, from social movements, from civil society. That's part of this process. That's why we call to the same table the indigenous and non-indigenous people to discuss the problems of the health and focus the problem, focus the solution. And that's my last statement. I would like to thank you for all, but it's a simple analysis. It's not so sophisticated, but using the real data and trying to figure out what the data can tell to us, what the data can improve our practice from the region, that because we are part of WHO organization, but how can I, when I go to the country and I show them the reality, how can I convince them that it's a problem and not be hiding that's the invisible, but make it visible and more, and improve it. So change the reality, transform your reality, and make a better world for all of us. Thank you.
Thank you so much, Fatima, in particular to draw attention to the inequality issues and the need for, for make that connection, what Richard Horton said with human rights, because that's what we're talking about here. The next presentation is from South Africa, where we already have now a second round of the A Burden of Disease study by Victoria Pillay-van, who's the specialist scientist of the Medical Research Council in charge of this study. Please, Victoria.
Good morning, everybody. As Peter said, I work for the South African Medical Research Council Burden of Disease Research Unit. I am doing this presentation on behalf of the South African National Burden of Disease team. There's many people involved. And in this presentation, I will be showing you some of our national and subnational mortality trends that we have estimated for the period 1997 to 2009. Okay. As I said, there's multiple people involved in the study. Most of our staff are from the Medical Research Council. However, we also collaborate with the University of Cape Town, Professor Rob Dorrington, and the Institute of Health Metrics and Evaluation, Professor Theo Vos. In this presentation, I will go through the following. I will give you a brief background on South Africa as a country and some information about the first national burden of disease study that we did. I will then speak to what I aim to achieve in this presentation. I will quickly go through the methodologies that we use to estimate our mortality trends. I will show you some main findings and do a brief discussion and conclusion. South Africa is classified as an upper middle income country and is located at the tip of Africa. It has 9 provinces, as you can see, that are indicated in the black. So this area here, this light region is South Africa. Lesotho is sitting in the middle. That is not a part of South Africa. It's another country. And all these black are basically speaking to the 9 different provinces. The Western Cape, which is, sorry, I'm like getting this, it's very difficult to point from this point. Western Cape, most of you know Cape Town, is regarded as a rich province together with Gauteng. Most of you will identify it with Johannesburg, which is its main city. The poorest province in South Africa is the Eastern Cape, that large area over there. Healthcare management in South Africa is decentralized to the provincial level, meaning that each province has a provincial government that actually is responsible for managing healthcare in the country, and this does have an impact on the burden of disease profile that each province has. And you will see that later when we look at the results. So a little bit of background on the actual mortality information. We do have a good vital registration system that is operational in South Africa that routinely collects vital registration. We do have a problem with under-registration of deaths, misclassification of cause of death, particularly for HIV and AIDS, and we have a 2-year delay in the release of the cause of death data. We can get underlying cause of death from the vital registration information. However, we have a problem with garbage codes. The first national burden of disease was conducted in 2000 and was led by the Burden of Disease Research Unit in of the Medical Research Council. Even though South Africa is classified as a middle-income country, it's different in the context that unlike other middle-income countries who have a double burden where they have not yet resolved the infectious disease burden and have started to see their non-communicable diseases rise, South Africa has a quadruple burden. So in 2000, we identified high burden due to type 1, that is your communicable maternal, perinatal, nutritional diseases, together with non-communicable diseases and injuries. And then we also identified that there was a huge burden due to HIV, AIDS, and TB. So we've been categorized uniquely as having a quadruple burden of disease. For the second burden of disease study, we adjusted the statistics for under-registration of deaths as well as misclassification of cause for that 12-year period. We identified that we had a 93% completeness of our vital registration, meaning 93% of the deaths were registered. And we identified 14.2% of ill-defined codes and 23.6% of essentially garbage. In this presentation, I will show you the age distribution of deaths by broad cause of death group, HIV, AIDS, and TB as its own group, followed by other type 1 conditions, the non-communicable diseases type 2, and type 3 injuries. I will show you national mortality profile for the 4 broad cause groups. I will show you a provincial mortality profile for the 4 broad cause groups for 2009. And then I will close by showing you the leading causes of premature mortality for the 9 provinces that I referred to earlier for the year 2009. Methods. Our vital registration data that we get, we basically get it as unit record data from the National Statistics Office, which is called Statistics South Africa. We basically did data cleaning on the data. We found that when we looked at our multiple cause data, there was a problem with diabetes. South Africa was very different in the context that our clinicians actually report diabetes in part 1 of the death notification form instead of part 2 as a contributory cause, which most countries do. So we had to recode the diabetes deaths for those where they were actually also have cardiovascular diseases also reported in part 1. So we recoded those with diabetes as underlying cause of death with a cardiovascular disease to a cardiovascular disease. We also found a very unique situation where we had epilepsy being reported as the underlying cause of death for stroke. So we had to recode those, and we coded those dates to stroke as underlying cause of death. We did not disregard our unknown age, sex, and population group data. We did a proportional redistribution. Professor Dorrington from the Actuarial Sciences unit at UCT worked on the completeness part of our study, and he did an empirical adjustment of completeness of registration. One of the other challenges we have in South Africa is clinicians don't actually report HIV as cause of death. So over the last 12 years, HIV has been reported as 2% of the deaths coming from clinicians for each and every year, in the vicinity of 2%. So we had to identify and reallocate all misclassified HIV deaths, and we had to develop a method to do that. We dealt with the garbage and the ill-defined. We redistributed them by proportionally. We also have a problem with injury data in South Africa. So basically, we had conducted a survey for 2009, a national representative survey of mortuaries in South Africa, where we identified what the 2009 cause profile would be by specific cause of injury. And then we used the cause profile for injury from the 2000 National Injury Mortality Surveillance Survey that was done. And then we kind of like extrapolated what the trend would be between those 2 periods to get our injuries. Death rates were calculated using the ASSA 2008 population estimates. ASSA is a well-known AIDS and health demographic model that has been created by the Actuarial Sciences at UCT. And we used AIDS standardized rates calculated by the WHO World Standard. Some results. This graph basically shows you the number of deaths, okay, by the 4 broad cause groups. We have injuries in green, non-communicable in blue, other type 1 in orange, and HIV/AIDS and TB in red. And what you can see from this graph that I would like to highlight to you is, you can see basically in 2003, we're sitting with a colliding epidemic. The HIV/AIDS epidemic collides with the actual NCD burden load that we've seen. The HIV epidemic had a rapid increase from the earlier years, and then we start to see a downward turn in number of deaths from HIV/AIDS and TB since 2006. We also see that the non-communicable diseases, number of deaths from non-communicable diseases, increasing over time. This graph basically shows the AIDS standardized rates for the 12-year period, looking at the 4 broad cause groups. It's interesting to note that the AIDS standardized rates are actually showing that the non-communicable disease burden is actually coming down over time in the latter years. HIV is still a major contributor to mortality rates in South Africa, but we do see the downward trend. We are also observing that green line, a very slight decrease in injury deaths in the latter years. This graph is basically showing us the age distribution of deaths for the 2 periods, the 1997 on the left-hand side, and the 2009 on the right-hand side. The colors are still the same as I used previously for the 4 broad cause groups, and it's given to you by 5-year age bands. You can see between the 2 periods that child deaths have decreased. if you look at the under ones. Child deaths have decreased. The burden due to HIV, AIDS, and TB, the number of deaths have increased in the younger adults, as you can see if you compare the left to the right. There was a high non-communicable burden in 1997. We also saw deaths in individuals from non-communicable diseases in the prior to 60 years of age. There's more deaths in the latter period, 2009, and what you can also see is the large number of deaths in the older age group is speaking to South Africa having a more aging population. So basically, I said that the non-communicable AIDS standardized mortality rates are coming down. However, what we're seeing when we look at the non-communicable diseases by specific cause, some are going down and some are going up, or starting to go up slightly. So there's a varying trend if you look at it by specific cause. And I would like to draw your attention to the blue line, which is hypertensive heart, which is starting to show an upward trend in the latter years, and the yellow line, which is diabetes, which is also starting to go up in the latter years. Note the red line on the top is stroke, cerebrovascular disease. It is decreasing in the latter years, together with ischemic heart disease indicated by the green line. I wanted to show you cancers, and we're going to look at them separately by males and females. Again, I would like to highlight to you the purple line, which is prostate cancer in males. It's increasing in the latter years, together with the green line, which is colorectal cancer. Important to note that esophageal cancer, the red line, and lung cancer is coming down in males. For females, I'd like to draw your attention to breast, which is the brown line, which is showing a slight increase in the latter years. Together again with colorectal, it's also showing a slight increase in the latter years. Important to note, esophageal cancer is decreasing over time. This slide is basically comparing the burden of disease estimates that we generated from the National Burden of Disease Study together with the estimates that the Global Burden of Disease Group generated for 2010. The first thing I'd like to draw your attention to in comparing these two estimates is the envelope. There's a very big difference in the envelope between the SA-NBD and the GBD. There's almost 100,000 death difference between the two estimates. Vital registration for South Africa, the data was just released recently, or the report was released, the data hasn't been released, is showing that we have over 579,000 deaths reported for 2009 in vital registration, unadjusted for completeness. The other thing I'd like to draw your attention to is that GBD is estimating over 10% more HIV/AIDS deaths than we are. They are also estimating less deaths due to non-communicable diseases, except for diabetes. And the reason for that could be is because we adjusted our diabetes deaths, as I mentioned earlier. Also important to note is that GBD is showing an injury category called accidental mechanical in their top 10 causes of death, while we don't actually see that for South Africa. We are seeing road injuries, which they are not seeing. We have engaged with the GBD group about these differences that we see, and we are working towards which way we're going to go in terms of moving forward. And earlier I mentioned that I will show you the burden by province, and so this is basically looking at the burden of disease for the 4 broad cause groups, the age standardized mortality rates. The colors are the same as I said previously. I'd like to highlight your attention to the last two bars, or the second last and the third last bar. Those were the 2 provinces I mentioned earlier that I said was the richer provinces in the country, and notice that the AIDS standardized mortality rate is lowest for Western Cape and Gauteng. And notice Eastern Cape, who I said was the poorest, as the highest AIDS standardized mortality rates. You can also see, if you look at the colors, that the burden of HIV/AIDS is different in the various provinces, together with the infectious diseases and the non-communicable diseases. This league table is showing you the percentage of years of life lost due to premature mortality for each one of the 9 provinces. It's been color-coded. I'm keeping the colors consistent. So the red colors will be HIV, AIDS, and TB. The green colors will be speaking to the injuries. The blue will be speaking to the non-communicable diseases, and the browny yellow colors will be speaking to the other type 1 diseases. And I would like you to look at the second column, And that second column is referring to Eastern Cape. Yes, it's referring to Eastern Cape. I want you to note that the 4 top causes of premature mortality for Eastern Cape are all still infectious, other type 1, speaking to the development of that province. While you can see non-communicable diseases are coming up higher in the other provinces, it's ranking much lower on the list for Eastern Cape. This league table is important for the various provinces and the provincial management of healthcare to actually look at the province at a glance to actually see what is actually going on. So in conclusion, despite the limitations of the data, there is a clear rapid increase in HIV/AIDS and TB rates with a downward trend since 2006. And we believe that this is due to the impact of treatment being available in South Africa and also access of that treatment. There's an overall downward trend in non-communicable disease rates, but it is different by cause. As we noted, we saw that some were going up and some were going down. So stroke and ischemic heart disease and esophageal cancer and lung cancers were going down, but hypertensive heart and diabetes were going up. There's large provincial variation in burden for the different provinces, and the league tables do help provinces identify their burden at a glance. Looking at those league tables, we see that HIV/AIDS and TB contributes to the most years of life lost due to premature mortality. However, the cause profile in each one of those various provinces is different. And each of our 9 provinces holds a quadruple burden of disease for South Africa. Thank you.
Thank you, Victoria, for a remarkable presentation, and also that you have already a history of applying this methodology and showing also how at subnational level it can really have a major function in policy development. The last presentation of this morning's session is from New Zealand by Martin Tobias from the Ministry of Health.
So I'd like to tell you a little bit about the New Zealand Burden of Disease study, and specifically tell you about the role of data linkage in the study. So not so much big data as linked data. So this slide just sets out the objectives for the New Zealand Burden of the Disease study to provide a bit of context. It's just that first objective I'd like you to concentrate on, which is what I'll be addressing today, namely the estimation of the descriptive epidemiology of the health conditions. So focus more on YLD rather than on the YLL side of the delimetric. Okay, so the methodology, this slide you may or may not recognize is a little similar to the one Chris showed. And our methodology was heavily dependent, of course, on the GBD 2010 assistance and approach. But I'm going to be focusing solely on one small segment of this, which is in the upper right-hand side of the slide, namely the use of the New Zealand Health Tracker, which is our data linkage methodology, to produce the estimates, particularly of prevalence underpinning the YLD calculations from the multiple epidemiological data sources that we have available. So what is the New Zealand Health Tracker? We think of it as a health census of New Zealand residents, updated quarterly. Perhaps I should actually first explain about the NHIs. It's anonymized deterministic linkage. It's not probabilistic linkage. It's all based on the National Health Index, the NHI, Unique Personal Identifier. It's an 8-digit alphanumeric code assigned to every healthcare user, actually every resident healthcare user, at first contact with the health system. And we actually, the data extracts that we get all have master encrypted NHI to avoid duplicates and to obviously preserve privacy. Now, I also need to explain to you what a primary health organization is. The PHOs are simply groups or networks of general practices that share administrative functions. There are about 40 in the country at the moment. And almost everybody is enrolled. Enrollment isn't mandatory, but the incentives for enrolling are so great that over 99% of New Zealand residents are enrolled. And the point is, of course, that the PHOs are funded largely through capitation. So the incentives on both PHO management and on the Ministry of Health to get those enrolment lists right is high. So we receive quarterly lists from the PHOs as to who they think is enrolled, and those are carefully scrutinized to avoid duplicates and to remove ghosts, people who have died or have moved overseas. So the PHO enrollment data set, when we pull all those 40 returns together, is a quarterly updated virtual population register. And it's because it has NHI in it, and all the data that we get from the other national collections also has its microdata identified by NHI. We can avoid or minimize numerator-denominator bias in this way. To be included in the denominator, an NHI must be present in the numerator. And in principle, all administrative data sets that use NHI can be linked, but of course we can only do that if the NHI completion rate is high enough in that particular data set. Okay, so from the PHO enrollment data set, we get our population. We get a list of all eligible people identified through their NHI, and we also get the core demographic data for each of those people. Then we add what we call indicators. Now, there are three kinds of indicators. A flag indicating the probable presence of a particular health condition, a count indicating a particular health service use over a particular period of time, and you can set that whatever you like, say over a year, and the expenditure associated with that service use. Now, the health condition indicators are mainly prevalence indicators, but as I'll explain in a moment, they can be incidence indicators as well. The other thing you can do is you can extract all the people from the data set, the integrated tracker data set, who have a particular condition or set of conditions, and then use that dynamically, longitudinally, to follow up for pathways of care, outcomes, whatever. So quite powerful to have a linked data set like this. So what NHI linkable data sets do we actually currently have? Well, beyond the NHI itself and the PHO enrollment data set, the population, we have about 18 other linked data sets at the moment. Now, I'm not going to run through all of them. It would take a while. And they're not all useful for health conditions. Some of them only useful for health service use and costs. But I will perhaps point out just a few which aren't immediately self-explanatory. Sort of halfway down the left-hand column, you'll see the laboratory claims collection. This collects data from community laboratories only, not hospital laboratories, and it's restricted to the type of test. It doesn't tell you the result of the test. Over on the right-hand column, second from the top, the national minimum data set. These are discharges from public and private hospital inpatient and day patients. The one below that, the national non-admitted patient collection, these are outpatient attendances and emergency department attendances. So I think you can see, I won't keep going, or perhaps I'll mention the pharmaceutical collection. These are dispensings of prescription medicines from both hospital and community laboratories, all classified by the anatomic therapeutic classification. Socrates is a disability database. I think you can see that we're quite lucky, and it makes life a lot easier if you have this available. So given access to all of these data sets, all micro data sets with every individual identified by NHI, how is an indicator created? And again, I'll focus on health condition indicators. So the first step to construct an indicator is to develop an algorithm, a set of criteria about which ICD or other codes in each of the available data sources to use to identify NHIs of people with a particular health condition. The key decisions relate to which ICD codes, how far back to look. That look-back period is a vital part of the algorithm. Whether there are any pathognomonic pharmaceuticals or combinations of pharmaceuticals. Whether there are any pathognomonic lab tests or combinations of lab tests. As I said, we don't have the results, unfortunately, at this stage, nor do we have diagnoses as such from primary care. This is why we have to use this somewhat roundabout way. And similarly, whether there are any purchase units in the National Non-Admitted Patient Collection which are specific enough to sort of identify the relevant, what the IC code would have been had it been there, if you see what I mean. And once this algorithm has been developed, the next step is then to validate the indicator. That's quite a process. And then obviously document it and then use it. And it's in the process of using it that often we will make refinements, fine-tuning the algorithm so as to improve the positive and negative predictive value. So this is just a summary, really, of what I've been saying notionally, what an excerpt from the integrated tracker data set would look like if it existed sort of as an Excel data set. So you've got a row for each person in the country, each resident healthcare user. I've shown 2 rows. There's now 4,485,000 of them. And then you have a series of columns. Firstly, demographic data taken from the PHO enrollment data set. Then a series, there's more columns than I've shown there. Then a series of columns being flags for the different indicators. I've only shown 3, but we have at the moment about 180 health conditions, most of them developed specifically for the New Zealand Burden of Disease study, but now, of course, available for other uses as well. Then there's about 16 columns for the different categories of service use, and the same for health expenditure. So this is an actual example of what a typical prevalence indicator algorithm looks like. I've taken the example of gout just to give you a feel for it. Let's say this is for the 4th quarter 2012. So a person, an NHI, will be given a value of 1 for the gout flag if either the person has received a discharge diagnosis of gout, ICD codes, from a public or private hospital from 1988 to 2012, first quarter 1988 to last quarter 2012. Why 1988? Because that's as far back as the NHI goes in the NMDS. Or being dispensed allopurinol or colchicine anytime between 2001 and 2012. Not probenecid, because probenecid isn't specific enough to use for gout. There are many other conditions for which probenecid may be used. And there's the next line is a little example of some of the detail that one has to sometimes get into. If it was, this is being based on a dispensing of allopurinol, then the person must not have had a diagnosis of a hematological malignancy in the 24 months preceding the first dispensing of allopurinol, because allopurinol is also used in the treatment of leukemias and lymphomas. And finally, the NHI, the person must be alive and still living in New Zealand as at last quarter 2012 in this case, as evidenced by any recorded healthcare contact during 2012. By healthcare contact, that simply could mean just being enrolled in a PHO. So that's a typical prevalence indicator. An incidence indicator is constructed in exactly the same way. The only difference is that you need to accurately identify first ever event, first diagnosis. And obviously, we have fairly short look-back periods because we didn't have the NHI going back that far. The shorter the look-back period, the more likely you are to misclassify a prevalent case as an incident case. So we use a retrograde survival model to derive a correction factor to correct for over-ascertainment of first ever events, which depends on the number of years of linked data available. So on to the next slide. If I have the time, I would mention one additional way you can add value to Tracker, which is that it's ideal, as many of you will have by now realized, I think, for capture-recapture methodology. So just very, very briefly, I've used the example here of coronary disease, the same principle as with gout. If people appear because of the common NHI on more than 2 lists, you can use capture-recapture to identify those who should have appeared but don't on either list. And I'd like to now just move on to an example of the way in which we are looking at the results from the burden of disease study, taking an example of some analysis where tracker has been particularly important, and that's in the relationship of health loss to health expenditure. Tracker obviously being central to both the estimation of dailies and the estimation of health expenditures. So in this slide, we're looking at the most sort of basic analysis, but one which I think is really important, which is by life cycle stage. So we're looking at all-cause health loss, all-cause dailies, and total government, publicly funded health expenditure by life cycle stage. So, for example, if you have a look at older people, the top right data point, older people make up only 12%, that's people aged 65 and older, make up only 12% of the population, yet they sustain 37% of the dailies. The x-axis shows the percentage dailies, and interestingly, they consumed 37% of publicly funded health dollars on the y-axis, and so on for the other age groups. Not quite so good a fit for middle-aged age group or for children, but overall, this sort of analysis, I think, does suggest that through good luck, I'm sure, rather than good management, the New Zealand health system is allocating resources to age groups pretty much according to need, so a high degree of generational equity there. It would be wonderful to benchmark this, see how that compares. And my final slide is a analysis looking at, no, that didn't seem to move. There we go. Looking now not by life cycle stage, although I could have, but this is for the population as a whole. But now we're not looking at all cause. We're looking just at a single cause group, namely cancer. So on the same story, though, here we're looking at types of cancer rather than life cycle stages. On the x-axis, you have the percentage of all cancer dailies represented by that type of cancer, and on the y-axis, you have the percentage of all cancer dollars. I should say that excludes prevention and 1 or 2 other categories of expenditure. And as you can see, the fit here, the correlation between dailies and dollars isn't perhaps that good, but I think what this sort of analysis does is it opens the can. It raises topics for discussion and for further investigation. And seeing I'm running out of time, I'll just mention one. If you have a look at the data point for prostate cancer, you'll see prostate cancer accounts for only 6% of cancer dailies, but consumes 11% of the cancer budget. Is this overspend evidence of overdiagnosis and overtreatment of prostate cancer in the New Zealand health system? Don't know, but it raises those sorts of intriguing questions. So, in conclusion, I think, yeah, big data, big linked data. Thank you.
Thank you, Martin. And it's good to see the nitty-gritty of how to link data sets. I'm not sure how you do it, but it seems to work. We've got now about a good 20 minutes for discussions, and there are roving microphones. Please identify yourself, and we'll take a few questions at a time. And unfortunately, I can hardly see anything with the light in my eyes, but who would like to start? Yes, please, here on the row.
Oh, I'm sorry.
Oh, sorry.
There we go.
Oh, here we go. Just on the. So, yes.
My name is Tanya Roberts from with nonprofit organization National. Can't even remember.
Yes, we can hear you.
Center for Foodborne Disease Research and Prevention. One of the things that we focused, or I focused on in my career as an economist, is looking at the long-term health outcomes associated with foodborne illness. And so I've seen how you've had a greater increase in the disability associated with various sequelae, which I'm very glad to see. But I guess the thing that I've noticed in my career is that there's this increasing recognition that there are long-term health outcomes involving mental conditions, involving arthritis, that can affect you for the rest of your life. And the scientific knowledge is evolving so rapidly in this field. I think that you would find that even though intestinal infectious diseases are going down, which is wonderful in terms of the cause of death, I think the disability is going to be a big increase over time. And I guess I would like some reaction to this.
Thank you. Yes, Richard Horton here in the first row.
Thanks, Richard Horton from The Lancet again. So, to Fatima, to Victoria, and to Martin, you presented data where your unit of analysis, Fatima, was the country, and Victoria was the province, and then Martin also looking at a country. So my question to the three of you is, you've got these data, how do you then use those data in a political process to get some engagement, whether it's from the government, civil society, other organizations in the country or province, to do something with it, so that the data isn't just about getting data, but it's actually leading to some action? What's the process that you've got to get data into action and then hold people accountable for using those data?
Okay, highly relevant. So why don't we start with these two questions? And I guess they were not addressed to anybody specifically, but who would like to start? Victoria, please, yes. Please, go ahead.
I'm going to respond to Richard's question about how we're going to use the data and the estimates that we've basically generated. South Africa's healthcare system is currently being re-engineered. So we are basically looking as to how we can get a national health insurance in place. And part of that process would be to do a situational analysis of what's happening on the ground. National government knows about the National Burden of Disease study and are eagerly waiting our estimates. They want us to take province further down to district, because district is a better planning unit than province. Province is still quite big. So we are working towards that currently to see if we can generate the estimates that they would need to actually plan how they're going to actually re-engineer this healthcare system.
Thank you. Yes, please.
Well, hello. Yeah, okay. Thank you for your question, Richard. Look, it's much more difficult for us from the region than from our country. If you was in my country, when we focus on analysis in a population group or in our trends or in our burden of disease, that's why we have a policy. And we would like to know, and we would like to set actions to improve the situation. From a regional perspective, it's much more difficult because we need to convince the other that they have a problem. And it has been difficult with some governments. Some of them tell me that, are you trying to increase our maternal mortality? So what are you trying to do, increase our problems? So make visible the invisible sometimes is not good for you, for your health especially. But yes, but other countries, yes, they are very committed, and we work together. So they are improving the information. I'm glad to see an example from me is Ecuador, because they are working hard to improve their information, and they are increasing their maternal mortality, because now they know they are producing better data, they are investigating, so, and the others not. But important is not give up. because we have to insist in this situation. No? We have to insist and come back and sell and tell and show and try to, don't know the words, but not try to make visible the problem, and at the same time show that there is a way. Because another problem that scares politicians, that oh my gosh, my reality is not so good as I have told to everyone, but there is a way. So at the same time that we show the problem, it's important to show that there is a way to go through this problem and make a better performance of our health system or our health policies or whatever social policies. But there's one question that is behind this, but you have to be brave in this process, or you'll be afraid to tell the truth. Because it's the other question. No, you can lie and hide the problem, or you can tell the truth at the same time and show, look, we will go together on this. Because we are committed with this transformation of the situation of the reality, make a better live in this country or in the world or in the region. But for me, it's a strategic. Try to make like a simple thing that every country should have a national committee, statistics committee, interinstitutional. Alan is here, present. He's in his manual. It is a recommendation, official recommendation. But it's so hard because it's the people are afraid of the information. People are afraid to know. So that's just a basic problem. So how can I tell that my situation is improving? If I have a bad information, it's better because no one knows. If my information is better, everyone will know. And work with this is very difficult. But show the way is the solution for us that you don't want to hide the truth, but want to do something. So but I have to convince them, they have to be my ally in this process. So that's our difficulty.
So on the question about the quantification of wild Ds from diarrhea, so in the GBD, obviously the short-term consequences are there. There are some interesting papers that are out there about links even through to Alzheimer's, as I'm sure you know. But those sort of things have yet to be incorporated. In general, in terms of assessing the sequela from a condition, we try to reflect sort of the state of consensus on the evidence. As that evolves, I'm sure our sequela list can also evolve.
Mm-hmm. Thank you. Martin?
Just in answer to Richard's question, I think this is the most...
Can you speak a bit closer to the microphone?
That is obviously the most important question to answer now that the machinery has been built and the results are available. I think we're fortunate that in terms of resource allocation and priority setting, we have a formal, structured, official process to feed the data into so that it can be used to influence those sorts of processes. If you don't have that mechanism in place, and I think it is important to build it perhaps at the same time as working on your national burden of disease study. In terms of the wider sort of issues, implications for equity and for broader government policy, that's a little more difficult to answer. What we're hoping to do, not that we really have it going yet, is to get deliberative dialogues going with key stakeholders, both parliamentarians, advocacy groups, technocrats, bureaucrats, and bring everyone together into deliberative dialogues where people try and come up with consensus views about different issues as informed by the data.
Thank you. Other questions? Again, if I don't see you, please shout because
Michael Wilson.
Oh, okay, Michael, please. Over there.
Morning. Michael Wolfson from Canada. Fatima, in a number of your slides, you had the word equity appeared, and Martin just mentioned it. And in the Lancet publication last December, Chris, there was mention that this is ideal but hasn't been done yet. What are the plans, if any, to bring in these sort of distributional factors?
Yeah, who can address?
Great question. A number of groups have called for an analysis by socioeconomic group within country, and another type of call for fine-grained geographic analysis, which is one type of view around inequalities. Interestingly, the latter, as you probably know well from your time at Statistics Canada, is easier to do than the former. For the former, for child health outcomes, because of the DHS, it's pretty straightforward to look at some types of equity distribution. But for many of the adult sequela, there's very few data sources that, unless you can get access to the underlying primary data and reanalyze, and many of the things that have gone into the meta-regressions, whether it's for epilepsy or for angina, don't give you that sort of information, whereas it's much more tractable to do the geographic lens. And I think there's interesting work underway already for China, for the UK, for the US, where that might start to feed in.
Thank you. Now I see a series of hands starting here in the second row with Tis, Buma, and then we'll move over there. I can, was the microphone here, please? Julio, and then over there a series. Yes, you and there.
Tis Burma from WHO. Question to Chris, whether you could say a little bit more about the new GBD. So, the GBD, as you said, is trying to describe the overall epidemiological situation globally, region, and countries. Now we've seen GBD 2010, which for the first time presents the trends 1990-2010 with some really powerful visualizations and some big changes in 2 decades. Now the new GBD, as I understand it, is going to focus much more on countries, being much more specific and getting more data, but it will also be an ongoing improvement process when new data become available, put them in, but also changes in methods. Now, epidemiological situations don't change year by year. So I guess in the data-rich countries, apart from major changes in the methods, it wouldn't really make much of a difference. In data-poor countries, and you showed Niger, for instance, if a new DHS comes out and, say, child mortality is 40 points lower, you can probably, through the models, get huge changes in cause of death patterns, which could be misinterpreted by others as major changes in malaria mortality or something else. Also, if there are major changes outside of Niger, major changes in the cause of death patterns within Niger can occur on an, say, annual basis because you have to borrow so much from other populations.
Okay, thanks. We'll take then over there in the middle corridor.
My question is to Fatima Marinho.
Can you identify yourself? Sorry.
Yeah, my name is Aisha da Costa from the Karolinska Institute in Stockholm. Thank you for a very nice presentation, Fatima. My question to you was actually about, you talked about the inequalities between countries and within countries in South America, but you also talked about how there had been quite a good GDP per capita had gone up from about 3,000 to 7,000 in the region. And I'm asking this question in the context of Anant Krishnan's paper in the Lancet, where he found better health outcomes with growth in GDP, although worsening of gender equity with regard to health outcomes. So I'm wondering if you were to look in in Latin America, which you presented, different countries have done differently with regard to GDP growth. And how has that growth affected equity and outcomes? The differential GDP growth, how has it affected the equity and outcomes?
Okay, thank you very much. And then on the other side of the row. Yes, please.
Hi there, my name is Karen Johnson from the McCall Center for Healthcare Innovation at Group Health, and I have a question for Martin. I am very impressed with what you've been able to do in New Zealand, and I was wondering if the linked data that you've been able to compile nationally, if you've been able to feed that back to the facility so that you can look at comparisons and improvement across the country.
Thank you very much. And then Julio, please. Frank.
Julio Frank, question to Chris. In other experiences, in other fields with big data, what's happened is that there's been the demands for the collecting and analyzing huge amounts of data has driven technological improvements. And the most dramatic case is the human genome with all the technological development to sequence at a fraction of the initial cost. But that was driven by the need to generate this data. So I wonder if you could comment on the technological changes that the massive global burden of disease has generated, not just to model, but also if there's in the future the potential of thinking of technological innovations for the collection of data, particularly as in other fields we're moving to, from bodily sensors and other types of technologies that might improve the reliability and the regularity of data collection. In a sense, how does one reduce the burden of disease in terms of collecting and analyzing data?
Thank you. Good question. And we have a last question. There was a hand. Yes, there in the middle, more or less. Yes. And then we'll go for the last series of replies.
Thank you very much. I'm Dr. Krishan Hiramatukada from Research Center, Southern Province, Sri Lanka. I'm having the two questions. One question from Fatima and the other one from Victoria. And first one from Fatima. You have shown us the slide regarding some comparative percentage of non-communicable disease, NCD, and infection disease in different countries like Mexico and Guatemala. So, but at a glance, when we see that the NCD percentage was low in the Mexico and Guatemala, sometimes it's very low in some other countries. Is it that you have shown as a age standardized percentage, or is it just a cause of death of just a percentage of the cause of death? It's just a percentage, or is it age standard percentage? But looking at that, we had an idea that the NCD was very low in some countries and very high in some countries. My second question to Victoria, we have shown a slide that hypertension trends was decreased over the period, but the stroke prevalence has increased up. So very recent abstract we have seen, which was published by American Society of Neurologists. It shows that hypertension is the main supporter of the stroke. It is, if the patient is having hypertension, it is more prone to have a stroke. The percentage of stroke patient is having hypertension is around 75 to 80%. So how you can elaborate on if the hypertension is coming down when the stroke is coming up? Thank you.
Thank you very much. I'd like to start. Chris.
Sure. So to Teese's question, I think that's an interesting question about how the world will adapt to a new time series each year. I mean, there's some good precedents out there. WHO publishes new TB numbers each year. HIV numbers are updated every 2 years, switching to every year now, it seems. Malaria numbers are issued by WHO every year. Child mortality numbers by UNICEF every year. And indeed, if you look at those reports, there's some pretty big shifts. And I think the piece in The Lancet, there was a letter, I believe, from Paul Farmer and others about the big shifts in TB numbers by country. So that's reality. I think as the data comes along and there's better data and better methods, changes will be both real epidemiological changes present in the time series that's produced, but also changes that reflect better, hopefully better methods and data. And I think we'll all have to look at some of those experiences and try to draw lessons about how to manage that process in the best way. To Julio's question around technology, I'd say yes, in two areas that we see, and I'm sure others will come. One is back on the technology of Bayesian statistical methods, where I think they're getting faster, better, and just cheap computational power and clever coding means that eventually many of these things that seem to take enormous computation will end up being available on a laptop. And I think that will disseminate those tools more widely. At the same time, I think people will come up with more and more clever ways to do things that do take the larger computational power. But on the technology of data collection, I think that there's lots of directions where, for example, cell phone-based or tablet-based data collection, that there are lots of groups trialing data collection. We're involved in some around verbal autopsy, but if you look out there, there's a lot. And those, if you redesign the way you collect data to say, what are the things I really want to know, or a government or a society want to know, and then back into how you get that information and what's the role of technology, I think that can be very potent, as opposed to what sometimes happens, which is this very broad sort of global architecture about an information system. But I think there's going to be quite a lot of technical innovation that we're already seeing and will start to be mainstream, that will shorten the lag time in data into these sort of analyses, and hopefully improve the quality as well.
Very good, yeah. The UK is making a major effort in terms of using the data from NHS and so on, but also from media and all that, so we can get a different look at the health situation of people. Yeah, Fatima?
Thank you. Thank you for the questions. First, we have different performance if you compare the countries. So first, the trends that I showed, since the 50s is a proportional mortality, we aggregate by 4 groups, GBD 4 groups, because we wouldn't have a problem with the GBD codes, maybe some, but our main problem would be the completeness of the data. The trend shows different performance. First, in the policies, because I will take an example from infectious disease, especially intestinal infections, or diarrhea. So if you improve the water supplies, I will decrease diarrhea, but there is a limit for this. So another part of this progress could come from the health services or some therapies like rehydration. It was very succeeded in the region, especially in some countries that have implemented this strategy and decreased the diarrheas. But at the end, we saw in the model that is a rate, that's trends, and we have some part of the population is still dying by diarrhea and malnutrition or respiratory diseases, and we have to focus more and more on our performance as a health services, because we can't work just in the average. Okay, our average is decreased, but could decrease more if I focus in some groups of the population. Like I showed the comparison with Chile and Guatemala, because Chile focused in the population at risk and got a better performance, even started in a low rate, or started in a rate similar to my country, Brazil. But another problem is the information that you got very well, but like, if I don't have a good completeness of my mortality system in the beginning of my time series, of course my risk is lower. I show lower risk, and when my information is getting better, my performance shows not so good because the information is getting better. But at least if I see an improvement and the information has improved also, I got a real decrease in that cause of death. That's what part of that we play when we analyze the data. Without other transformation of the data, we just redistribute the ill-defined cause of death, and for the model, not for the proportional mortality, and we
can see, and so I always try to show the countries that we can use the information available. So even if it's not good, but if it's good enough for a good analysis, and if we know the problems behind the information, we can make a good analysis, we can show, and we can use this for monitoring our priorities and policies. That's our point of view. So that's why we push this process in the countries and in the region. But work with it we have. It's better have something than have anything. So we go on and looking at the problem. Maybe, sorry for the time, but I see this fusion between academics, innovative theories and metrics with who is doing the work at in the country at local level. That's why we are together in this process. That's why I learn from experience like the IHME, and we learn from experience from local level. We make this fusion and go on with our experience, our knowledge, our theories, improving our practices.
I agree. That'll be essential for the ultimate impact. Victoria, please, you had some briefly, because we're running over time.
So hypertensive heart disease is one of those conditions that we know that our doctors in South Africa do have a problem with the coding. It's also one of the conditions that we had that looked very different from what the Global Burden of Disease group was indicating for South Africa, and we engaged with them and we readjusted the way we actually dealt with our garbage and came down to a similar number, 2 GBD. So we know there is a challenge with hypertensive heart disease. The national trend that you are seeing is not reflective of what's happening at province level. So if we had to look at trends at province level over the period, we will see that for some provinces it's going down, like stroke, and there are a few that it's going up. The drastic decrease that we're seeing in stroke since 2003, we believe, is because of the introduction of folate fortification in food in South Africa.
Thank you.
So I'll be very brief. At the moment, we use Tracker only as a statistical tool. The next challenge would be to use it as a clinical management tool at the individual patient level.
Thank you. Well, I think we had a great start for the week, for the conference. What was for me maybe the biggest surprise in the GBD 2010 was that the transition, the epidemiological transition, is going much faster than I had anticipated, which I think is a strong argument also for this continuous update and not waiting for another 10 years. Giving the impact for prioritization and policy setting. So the GBD is entering into a new phase, and we heard from Chris a few elements of that. It's not only a continuous update, and we should also be realistic what can be delivered, and remind some people who called for an alternative and they want to have the ambition to do, an other kind of a burden of disease study. They should realize how massive this effort is. It's not only in terms of people involved, but also the data collection, the data management, etc. I think also that for me what's key is that the current exercise has identified, I think, major gaps in our knowledge and in the primary data. And that may become the biggest obstacle to refining what we have been doing, what the world will need. And I always wonder who's going to invest in that, and why is that not really an essential part of the health agendas and the development agendas of the future. Not only in terms of narrow definition of health, but also linking it with other indicators that showed up, I think, on Fatima's slide, on the first one. The methodology will change, I guess, also because of the revolution in information, data handling and collection and so on. And that also is going to increase the pressure for solving the problem of access to data. Because I suspect that what you've done now, Chris, and with all your partners, is that you must have now the largest data collection on disease patterns and etc. In the world, and that can be mined for other purposes as well. So there are many issues that are generated by the work you've been doing, which is great. And all this is, of course, not without controversy, including like in my own London School of Hygiene and Tropical Medicine, where we had a debate I think in January or December, that Richard Horton was co-hosting with Martin McKee. And some of it is pure turf, and I think we should just basically regard that. But then other things we have to listen carefully and see how collectively we can improve this effort, which I think should become, like for each country, as important as the publication of the, the GDP. The other, you have GBD and GDP, and we all know, and that's rarely discussed, that the the gross domestic product and equivalents. I always wonder how can they publish this with so much confidence on a quarterly basis. It can make or break careers in politics and so on. Must be quite. It's even more complex than what we're trying to do here. Now, as you could read in the commentary in the Lancet on GBD 2.0, I will chair a committee, an international committee that is going to advise and guide the next phase of the GBD, and we are working on that now to develop it. We're having a board meeting also of the IHME later this week, and so I hope that soon we'll have this committee in place. It's not to say what should be done, but really to be also an interface between the GBD community, because I think it's a community with with our master, Chris Murray. I'm just back from Japan, so I'm influence of that, and then the broader world, and ultimately, as Richard Horton rightly asked, we have to think through what is the impact and on policy making and prioritization. And of course, their burden of disease is only one of several elements, but it's really great that in the next phase also health expenditure will be in their review of cost effectiveness and so on. So at the end of the day, I think this can grow into something that is a truly comprehensive instrument for decision making, and that is for me the historic context into which we should look at the GBD. Okay, so and that's really important, because when you look at the current discussion in the international scene on the development agenda, health is now so marginalized that I think that should be a wake-up call for us as a community, where we've been talking to ourselves and thinking that if we have a meeting with good arguments, that is going to result in having health on the top agenda, and we have now evidence, this evidence-based, that this is not enough and that is not the case. And I think a strong, comprehensive, all-encompassing approach to health, or analysis of what the health situation is, could help greatly in in ensuring that health remains on the development agenda. Okay, so we have now a break, and we'll resume at 11 o'clock with a session on measuring effective coverage of interventions, going into the evaluation part of the conference. Thank you very much.